Welcome, everyone. Welcome to Westover's first ever webinar. Today, we're using this get-together as a substitute for our regularly scheduled luncheon series. We look forward to resuming all of our in-person client events, including the luncheon series, as soon as we can do so in safety. Those of you who are on this webinar are either Westover clients or are exclusive, by invitation only, friends of Westover. You're in for a special treat today. Our guest is Dr. Ben Starnes. Ben is an internationally recognized surgeon, a professor, an entrepreneur, and a 15-year active duty U.S. Army Medical Corps veteran. For our purposes, we will use the first and the last of those characterizations. What's unique about Dr. Starnes is that he has literally been on the front lines of crises, fighting them, preparing responses his entire adult life. He treated the victims of war, providing surgical services in Kosovo and in Iraq during his 3 tours of duty as an Army surgeon. He also led the Walter Reed Army Medical Center surgical team to the scene of the 9/11 attack on the Pentagon. And most recently, he's helped plan the medical crisis response to the coronavirus pandemic as it first washed ashore in our country in his home state of Washington. I want to share one backstory about how Dr. Starnes, whose birthday it is today, by the way, so happy birthday, Ben, about how he and I connected initially, and a second showing the values of trust and compassion he learned from his parents. In the spring summer of 1999, when I was a practicing attorney and Westover had not yet been established, I would establish it in November of that year, I was retained by Ron and Martha Starnes, Ben's parents, to draft their estate planning documents. During that process, I got to know his parents quite well. Ben's mom was an elementary school teacher in the Newcastle County School District for over 40 years. She taught learning disabled and emotionally handicapped children, as well as first and second graders that entire time. Ben's dad was an 18th century furniture maker extraordinaire, and they lived in a house in historic Odessa, which was featured on the front page of Colonial Homes when Ben was a child. When he wasn't crafting furniture, Ben's father was a college professor of philosophy as well as a United Methodist minister. Ron died in 2002, Marty 2 years to the day later in 2004, and I was retained to handle and settle their estates. It was then that I interacted with Ben quite often, first met him and his wife Margie, and they became clients of Westover at that time, and they've remained stalwart clients ever since. I'll leave you with this second story. It's not a fable, but it's a true retelling about how the Starnes family demonstrated their values of trust and compassion for their fellow man. In 1967, a stranger traveling with his 3 children suffered a car breakdown outside the Starnes house in Odessa. Ben's father came outside, invited the family in, and gave them dinner. The family was going north to Massachusetts from South Carolina to say goodbye as the stranger was leaving for his tour of duty in Vietnam. Recognizing that he could not get there, Ben's father literally let them the Starnes vehicle to travel north, fully trusting that when the visit north was over, that the car would be returned safe and sound. Sure enough, it was, and that's precisely what happened. Imagine that happening today. So you can see that Ben grew up in a family with compassion for his fellow man. I'm sure you're going to be very interested in what he has to say regarding this pandemic and how he and his fellow physicians have dealt with it, trying to contain it, trying to repel it in Washington State. And with that, I'm going to turn the program over to my colleague, Matt Beardwood.
Thank you, Murray. I'd also like to welcome all our viewers and thank you for joining us. My name is Matt Beardwood, and I'm the Director of Wealth Management for Westover Capital. Today's program will be available on demand after this live session and posted to our website. There you will find a link to Dr. Starnes' material and his biography. You will also find additional Westover-related content, including videos of past events and our entire article library. Find us at westovercapital.com. Next, we'd love to hear from you during today's presentation. If you have a question for our speaker, please feel free to send it through the live chat box on the right side of the live stream page, or you may email your questions directly to me at matt@westovercapital.com. We'll be sure to save some time at the end of this prepared remarks. Lastly, we are live streaming this event on our Westover Capital YouTube channel, and I encourage you to share today's webinar with your friends on social media by posting directly to Twitter, Facebook, or LinkedIn. Now I'd like to kick things off by welcoming our presenter, Dr. Ben Starnes. I'm sure most of you saw Dr. Starnes' biography on our website or our webinar invitation and his CV that is posted on the event webpage, so I won't repeat that other than to say Dr. Starnes' accomplishments are impressive. He's reached the pinnacle of his profession in the field of vascular surgery, serving as a professor of vascular surgery, chief of the Division of Vascular Surgery, and vice chair of the Department of Surgery at the University of Washington School of Medicine. He also holds the Alexander Whitehill Clowes Endowed Chair in Vascular Surgery. Prior to joining the University of Washington, Dr. Starnes completed a distinguished military career, serving 15 years in the U.S. Army Medical Corps as a 61 whiskey specialist, achieving the rank of lieutenant colonel. Dr. Starnes served in 3 combat tours, 1 in Kosovo and 2 in Iraq, and was presented with over a dozen individual military awards, including 2 Bronze Stars. When asked in an interview what his most memorable surgical case was during his military service, Ben shared the story of a medical procedure he performed on an Iraqi civilian named Aida. At that time, she was a newborn, just 2 hours old. Aida was born with a tracheoesophageal fistula that, if left untreated, would have resulted in her death. And needless to say, Dr. Starnes successfully performed the surgery, and Aida is still alive to this day. As his Twitter bio reads, Dr. Starnes is a dad, a surgeon, a combat vet, a mountaineer, a Harley enthusiast, co-founder of Aortica Corporation, a woodworker, and a 9.3 handicap golfer. Dr. Starnes' background and experience make him uniquely qualified for the fight against COVID-19, and we all look forward to hearing more about his experience on the front lines. And with that, I'll turn it over to you, Dr. Starnes.
Thank you, Matt and Murray, and that was a very gracious and kind and thoughtful introduction. I'm going to share my screen with everyone, and hopefully everyone can see this now. I'm delighted and honored to be giving the very first webinar for Westover Capital. We live in extraordinary times. And I'm just pleased to be here and to spend the next 30 minutes or so with all of you. This is me at the tender age of 24 in 1990. I was attending officer's basic course in San Antonio, Texas, and had been lucky enough to be awarded a scholarship from the U.S. Army to attend medical school, as my parents did not have the means to pay for me to go to medical school, being the youngest of 3 boys, and them having already spent the amount of money on 3 college educations. I did my general surgery residency at Walter Reed General Hospital from 1992 to 1998. I graduated and was deployed to Heidelberg, Germany. This is a picture of my friend John Bruce and I, affectionately known as Trapper John, and my name is Benjamin, so people would call me Hawkeye, based on the episodes of MASH that everyone knew and loved. This is in Kosovo in 1999. This was my first combat deployment after being married for about 3 to 4 months. I came back to Walter Reed and did my vascular surgery advanced training with these fine people, Sean O'Donnell, Dave Gillespie, Jim Goff, and Ginny Parker. And during that fellowship, as Murray explained, I was the only person that had combat experience in our department at Walter Reed from my experience in triaging casualties in Kosovo. And so I was sent to lead a surgical team on that fateful day of September the 11th to the Pentagon and to treat casualties at the scene, as well as to help try and manage the situation there. For that, I was recognized by First Lady Laura Bush on national television on the morning of September the 12th. On March 23rd, 2003, 17 years ago, my unit was deployed in support of the 173rd Airborne Brigade to seize an airfield in northern Iraq at the very dawn of the war. This was a massive event. The logistics were incredible. Trying to divide up people and not put every one of your assets on the same C-17 to deploy into Iraq, as if one of these planes was shot down, you would lose an entire capability. This was a massive scene with 17 C-17s lined up tip to tail and 1,000 paratroopers. This was a very strange place, much like the strange times that we live in now. This was Kirkuk, Iraq. We took 3 cities, Mosul, Erbil, and Kirkuk. This was the oil-rich city. And this is a very interesting place. What you see in the background there is just pipes driven into the ground because the methane gas leaches from the earth and they need to burn it off. Otherwise, it just fills the air with methane gas. We were forced to operate in tents where we had air conditioning, but the temperature was a nice cool 98 degrees in the summer in Kirkuk. So we had to operate essentially naked under gowns. We performed all kinds of surgeries, as Murray explained and Matthew explained. This gunshot wounds, mortar wounds, blast wounds, IED injuries. I won't show you any gory pictures, but there aren't many surgeons in this country who've operated on 2 patients in the same operating room at the same time. You can see how crowded it is in this operating room. In the lower right, I'm here with my colleague, John Devine, doing a repair of a brachial artery injury. This all had to be carefully orchestrated, and we had these beautiful state-of-the-art operating room lights about the size of a Coke can. I'm being facetious, of course. Fast forward several years to Harborview Medical Center, the busiest level 1 trauma center in America here in Seattle, covering 5 American states: Washington, Alaska, Wyoming, Montana, and Idaho. We see everything here, and it's a pleasure to practice in this modern trauma facility, and not something that I'm not used to. You can see here, this is the operating room that I work in. This is OR 17. You see these big, beautiful lights compared to the ones that we had in a tent in Iraq. But we have modern imaging, modern negative pressure ventilation rooms, and it is truly a pleasure to work in this luxurious hospital. I'm going to take you to ground zero, which everyone knows that in Seattle, the first patient with COVID arrived into Seattle on January 19th, and this was confirmed by our public health department on January 22nd. On February 20th, Helen Shu helped identify the first community-acquired case in a 17-year-old male who was about to return to high school in Renton, Washington. And the first U.S. reported death from COVID-19 occurred in our state on February 28th, 8 days later. We took this seriously in Washington State, having seen the first cases. And on March 9th, our dean canceled all work-related travel at the University of Washington. 3 days later, on March 12th, all elective surgery was canceled at the University of Washington. And that weekend, on March 15th, having known surgeons from all over the world, we saw what was happening in Italy. And I made a phone call to 2 individual surgeons. One was Pier Antonio Grimaldi, and the other Germano Melisano in Milan. And this phone call absolutely shocked me. They told me that they did not have enough ventilators to treat all of the patients. They said if a patient was age 80 or older and they needed a ventilator, they were made DNR, or do not resuscitate. They warned me to stop operating, to stop everything, and to conserve personal protective equipment. I took this seriously and began to craft a letter. And I crafted this letter to all of the vascular surgeons in America. And this was published online on March 20th. This is the letter that came out on the website a little bit later, but I'll share with you this number right here. Within just a week, this had 53,000 shares. This spread across America and helped us to scale down our operations so that we could conserve personal protective equipment, which is clearly what we need to do in a pandemic. I did a podcast the next day. This is a podcast called Audible Bleeding. It's a great podcast for aspiring young surgeons. And you can see since the inception in 2018, they had never had more than 500 hits. When we did this podcast, it had 1,200 hits in just one day. This is a list of current Washington COVID cases as of May 25th. And you can see, I showed you that curve before that ended on March 9th. This is what we saw. This is that early experience just expanded. And you can see that we were seeing a large number of deaths, 22 deaths out of 172 positive cases. And that was all the way back here. Now we're up to 20,000 identified cases in the state of Washington and only just over 1,000 deaths. This is the Institute for Health Metrics and Epidemiology. This is a website that many of you have been familiar with. But if you look at Washington State, we did a very, very good job here, and our public health system was able to keep resources conserved. By early actions, we were able, if you look at this purple bar here, this purple bar represents the capacity for ICU beds and all beds. And we never exceeded capacity in Washington State. In New York, however, you can see that that line is much lower, and they were predicted to go way above that capacity and not to have enough beds. If you look at a logarithmic scale of this data, which is the way the epidemiologists prefer to look at it, we have flattened the curve in Washington State. We've seen the daily number of cases decrease over time in Washington State. And in King County, just the other day, we only had 9 cases reported in a single day, which is dramatic. And it's a direct result of our actions early on during this pandemic. The lessons that we learned were that we don't get to choose when a pandemic occurs. Nobody does. We don't get to choose whether we're a part of this pandemic or not. But we do get to choose how we respond. What I learned in the military through my combat deployments and my experiences in my career are that there are no emergency surgical procedures in a pandemic. Sorry, I want to go back to that slide. The ultimate role of a surgeon, despite what anybody will tell you in a pandemic, is to help grow hospital capacity by not operating and preserving professional protective equipment. Surgeons can play a role by helping to put in central lines, central venous lines and arterial lines, putting patients on ECMO for cardiac support. But the most important thing that we learn in the military and elsewhere is to preserve the 3 S's: staff, that's personnel, space, and supplies or stuff. This was a news conference that Andrew Cuomo gave on March 26th. I've been very impressed with his leadership in New York State. And I call your attention to the surge of the healthcare force. He had requested 40,000 volunteers to come to New York. And where on this list do you see a surgeon? Nowhere. Okay, anesthesiologists, emergency room doctors, intensive care unit doctors, infectious disease, pulmonologists, nurse practitioners. Surgeons need to get out of the way. We went to the length of establishing what our definition of vascular surgical emergencies was. And this would be defined as a ruptured abdominal aortic aneurysm. We have created a risk score that has become the standard across America and elsewhere for identifying those patients with a 100% risk of mortality. A severe blunt aortic injury, arterial hemorrhage acutely, complicated type B aortic dissections, acute limb ischemia, symptomatic carotid disease, septic feet requiring amputations, and other venous emergencies. The bottom line is that we scaled everything back to only doing the true emergent cases. We've treated several patients with gunshot wounds, stab wounds. People don't like staying at home. They still shoot each other or themselves, and someone has to take care of them. So we've learned that operating in a pandemic involves self-preservation. We stopped allowing medical students come observe cases in the operating room because they were consuming professional protective equipment, personal protective equipment. Our residents, we had to manage. We had a resident who was positive for COVID-19. We have a pregnant resident. And all of these things come into play when you're responding to this pandemic. We all had to be fit tested for N95 masks. We constantly use hand sanitizers. If you do not pass the test for an N95 mask, you have to use PAPR hoods, which are very difficult to use because you can't hear anyone speaking in the operating room, and no one can hear you talking in the operating room. We had to decide about COVID testing or non-testing. If we had a patient that needed surgery emergently, we would bring that patient into the operating room. The highest risk to the staff is the period of induction of anesthesia and endotracheal intubation. That's when aerosolized particles go into the air of the operating room and put the staff at risk for infection. We had to assume that all patients were COVID positive until proven otherwise. Now we have the ability to do rapid testing, but we also use negative pressure ventilation operating rooms. And so what that means is that all of the air in that particular operating room is recycled within 30 minutes. It's completely sterilized of all of the aerosolized particles that could spread COVID-19. So just the other day, I had a patient with a gunshot wound to the brachial artery. We had a tourniquet up around his proximal arm, his upper arm. We had the anesthesia team go in with their protective equipment, intubate the patient. We waited 30 minutes. The operating room air was clean. We came in, prepped and draped, and did the procedure. This is how we have to function as surgeons treating only emergencies in a pandemic. We also had to switch to using Zoom and to helping our colleagues around the world understand what was about to come their way. This was on April 23rd. This is a colleague of mine from Adelaide, Australia. This is a colleague from London. This is a colleague from Hong Kong. And I was the lucky guy that had to get up at 1:30 in the morning to be on this webinar and share information with these folks around the world. Ian Loftus right here in London had 7 colleagues, 7 attending surgeons on his team, and 4 of them had tested positive for COVID and were in quarantine for 2 weeks. So you can see how the staff can get reduced dramatically, and you have to preserve your staff, your supplies, and your space. We have changed the way that we do faculty meetings. This was on April 24th. This was a division faculty meeting. You can see with 25 participants. We have a large division. And we have to continue our mission of teaching the next generation of vascular surgeons. We conducted our mock oral examinations virtually using Zoom, and were successful in doing so. Again, May 5th, just earlier last month, we did a live webinar that was broadcast nationwide to help educate the endovascular therapy specialists around the country with several national experts. Well, Shakespeare said, "We have seen better days." In April of 2020, these statistics may be shocking to you, but COVID-19 killed more people in April than any other cause of death does in a typical April in the United States. COVID-19 deferral of elective surgery occurred first on March 13th by the American College of Surgeons, then on March 14th by the Surgeon General, March 16th by Washington State, and then the Center for Medicaid and Medicare Services on March 18th. We had to do this to grow acute and ICU capacity and preserve the workforce. We now have to decide how we're going to come back. We had to develop workflow for our providers. We needed additional providers to cover COVID-related clinical care. It was a fluid situation. It was like building an airplane while it was flying. We needed to have backup to help manage some of our overburdened workforce that were suffering from fatigue, illness themselves, and family and personal reasons. These were also opportunities for us to publish. This was the University of Washington experience in restructuring the general surgery residency during the pandemic. And this was published in the Journal of the American Medical Association. We had to decide how to redeploy our residents and faculty attending from different services. And you can see here how many of these specialized services were impacted. When we look at the Institute for Health Metrics and Epidemiology, just in the middle of last month for Washington, you can see that with our actions, we only had 17,000 cases and roughly 1,000 deaths. We never exceeded our acute care or ICU bed capacity. When you contrast that to New York, which is the state that has been hit the hardest, they didn't have 20,000 cases. They had 337,000 cases with 22,000 deaths on May 10th. And at the peak had 1,000 deaths per day, more in one day than Washington State has had the entire time. They exceeded their bed capacity by 7,000 beds and exceeded their ICU capacity by 5,000 beds. I think a lot of this has to do with the fact that this virus was in New York before anybody knew it. And with the tight confinement of people living very in close proximity to one another, this was devastating to New York. This might come as a shocking statistic to everyone, but I'm going to tell you that we live in the greatest country on earth. And although some might not think it these days, with some of the challenges we've recently seen, in the United States, we have 34.7 ICU beds per 100,000 citizens. You contrast that to Italy, who has only 12 ICU beds per 100,000, and Spain, 11 ICU beds per 100,000. And quite shockingly, if you look at the United Kingdom, they only have 6 ICU beds per 100,000. That's the National Health Service of the United Kingdom. So very hard hit in Europe. If we look at the COVID death rates, you can see that Washington State fares fairly well here compared to other states. You can see New York is leading the curve there, and other countries. If we look at United States death rates, you can see that Washington State has a very shallow curve here with very few reported deaths per 1 million people. You see this sharp uptick in states like New York, Michigan, New Jersey, Louisiana. Travel reductions by US county. We were the first county to decrease our mobility in the United States. You can see King County is this bubble right here. This is counties with stay-at-home orders by March 27th versus counties without stay-at-home orders. And look at the distance that we stopped traveling. Travel fell dramatically in Seattle from an average of 3.8 miles per day to 61 feet on March 27th in just 1 month. Our public health system was very aggressive in instituting stay-at-home orders, and the statistics show that Seattle has fared better than most other cities in America. Well, what about coming back? This has caused serious financial challenges for all healthcare organizations, primarily because of lost clinical revenue due to cancellation of elective procedures, but also because of new expenses directly related to COVID-19, such as PPE, testing expenses, etc. And there have been loss of financial revenue due to lost opportunities to implement new programs. Our estimated financial losses at the University of Washington will exceed $500 million or $500 million by the end of the summer. In April alone, the University of Washington lost $70 million. We have to maintain our guiding principles and be committed to our mission of improving healthcare quality, continuing the excellence of our clinical research and educational programs, and providing the best possible care and support for our faculty, staff, students, and trainees. Some of the additional actions that we have taken to provide financial stability include reduction of compensation for senior leadership. Our dean took a 20% pay cut of his total salary. Our senior leadership, the CEOs, COOs, CFOs of all of the hospitals took a 15% pay cut. Our department chairs have taken a 10% pay cut, and our faculty have taken a 5% pay cut. We have had to do lean operations. We have had to limit our new recruitments to new positions of critical importance. We've had to postpone capital expenses that are not considered mission critical. And we have had to execute voluntary and required furloughs and FTE reductions, which is full-time equivalent reductions. How are we going to come back? In order for us to come back, we have to see a decline in new cases, and we have. We are back to full speed here at the University of Washington. Our clinics are humming. Our operating rooms are full speed ahead. We're operating with full operative schedules and trying to erase the backlog. We have to have a decline in new COVID cases, COVID hospitalizations, and COVID deaths. We have to increase our testing capacity. We have to be able to perform contact tracing. We must have sufficient personal protective equipment and maintain the ability to respond to a resurgence or a phase 2 of COVID-19. And when will patients feel safe re-entering the healthcare facility? The last few slides I'm going to show you are our backlog. If you look at our urgent case backlog, we have 265 urgent cases at Harborview, 184 at UWMC Northwest, and 769 at UWMC Montlake. But if you look at the elective case backlog, that's knees, hips, elective cases, hernia repairs, spine surgery, there are over 1,000 cases that need to get done in the immediate term. It's time to ramp up the operating room. And this doesn't come without cost. And I'll say that, we are considered to be on the front line of the COVID-19 pandemic. That's not true. The people that are on the front lines are people like Alex Bowman. Alex was an ICU nurse who worked at Harborview on the 9th floor in one of the ICUs, and he contracted COVID-19 and lost his life. These are the true heroes. So, lessons learned. As I stated before, we don't get to choose when a pandemic occurs or even if we want to be a part of a pandemic, but we do get to choose how we respond. Good decisions, not good choices. There is no emergency surgical procedure in a pandemic period. The ultimate role of a surgeon in a pandemic is to help grow hospital capacity by not operating and preserving personal protective equipment and preserving the 3 S's: staff, space, and stuff. This is my surgical team at Harborview with Mount Rainier in the back. It's been quite some time since we've been able to stand this closely together, but I'm confident that with our actions during this pandemic, we will be back to this setting in a short period of time. Thank you very much. I'm going to stop sharing my screen and hopefully be able to answer some questions for everyone. Thank you.
Thank you, Dr. Starnes. Thanks for the great comments, remarks, and your perspective. We do have some questions, and just a reminder, if you want to ask a question of Dr. Starnes, please feel free to either type it into the live chat box, or if easier, you can email your questions directly to me at matt@westovercapital.com. Looks like we do have a few questions here, Dr. Starnes. First one is, what percentage of the deaths in both Washington and the United States should not really be attributed to COVID-19?
Oh, that's a great question. So I think what you're asking is, are the death rates really accurate? Are patients dying of COVID and not from COVID, or dying with COVID positivity? I think there are a lot of patients out there who come to hospitals who are already suffering from other underlying conditions who turn out to test positive for COVID. And although they die of natural causes, they die with COVID. And so they're getting counted into that number. And that's an interesting point. I think that there are certain states who are starting to divide those numbers out. They're trying to separate patients dying purely from COVID as opposed to dying with COVID. Our death rates in Washington State are hovering right now at about 5.9%. That is a real number. That is over 1 in 20 people who become infected with this virus succumb to the disease. This is a racist virus. This is a virus that affects people of color more so than it does Caucasians. People of disadvantaged socioeconomic status are suffering more in the way of complications from COVID.
Thank you. Another question here coming from one of our viewers. He says, I had the privilege and honor of knowing your father during the 80s and the 90s, and we shared several experiences in common. What do you see as the role of the federal versus the state governments and the private sectors in terms of preparation, distribution of supplies, and response?
Oh, that's a great question. I think that may be above my pay grade, but I would tell you that I think that this has affected our country in such a profound way that they won't catch us again looking the other way. I think the next time that we have something that is of this caliber of a threat, we will be prepared. We will have systems in place. We will know how to respond. We will have policies and procedures in place on both the local, the state, the national level. We will be prepared for the next pandemic.
Thank you. We have another question. What are the 3 major changes you and your team will do differently going forward as a result of this pandemic?
Very interesting. So I think that although a lot of people didn't use virtual technology in the past, Zoom conferencing, for example, it is here to stay. It has made our lives much more efficient. We are conducting meetings in half the time that they would normally take. I did a conference call as president of the Western Vascular Society. We did a program committee meeting that usually takes 3 hours and only took an hour and a half, half the time. I think that it's giving us an opportunity to, I had to, as president of the Western Vascular this year, I had to cancel our live meeting in September in Santa Monica, California. We just couldn't continue to do it. So we're going to continue to have the meeting, but we're going to do it virtually. But we are going to expand the meeting. We're going to have the ability of having more attendees from around the country and around the world come to our meeting and to participate in the scientific sessions. We will miss the interactions with our colleagues, but I think the virtual piece is going to become part of our lives moving forward to hit the first spot. The second spot is I think that we are cleaner. We are a cleaner society now. Everybody is sanitizing their hands. Everybody is becoming a germaphobe. Everybody is wearing masks. I don't think that the mask thing is going to go on forever, but I think we are going to become a cleaner, more sanitary society. And this may even help cure some of the diseases that are out there, like the common cold. People are talking about that. And I think that it's also led to changes in policy in terms of public health. And I think that we are making changes in our operating rooms to be much more careful about protecting our staff and protecting our faculty.
Great, thank you. We had a lot of questions flowing in. I don't think we'll be able to get to all of them, but I appreciate the questions, everyone. I'll maybe do a couple more here. Question, do you have data on countries like Denmark and Sweden regarding ICU beds per 100,000? I understand they have great healthcare systems.
You know, I don't have data on Sweden. I could get that. I just don't have it with me right now. But Sweden is right up there around 15 ICU beds per 100,000. So they're a little bit better than Spain and Italy. They do have good healthcare systems. They let the virus go. They practice social distancing, but they did not shut down or have a stay-at-home order. You have to remember, though, if you've ever been to Sweden, I've been there 3 times, and things are pretty spread out over there. And people live at a distance from each other, and it's not very heavily or densely populated. So I'm not sure that we could make those comparisons.
Thank you. Why do adolescents appear to be less susceptible to COVID-19 in your opinion?
No one knows. It is very interesting. We looked at California, the states of California, Oregon, and Washington, and there were 0 deaths in the age group of 15 to 24. 0. So that statistic alone tells you that the younger populations are protected somehow from this COVID-19 pandemic. And it's the people with the underlying conditions that suffer the most. I would also say that going back to college is going to be something that I think we just must do. We're going to have to allow our kids to go back to school, back to college. And if we have that reassuring statistic that the 15 to 24 age group, there were 0 deaths in 3 large American states, that's pretty impactful. I know my daughter's a freshman at the University of Michigan, and they are talking about coming back in the fall, but limiting their semester to start a little bit earlier and to end in November at Thanksgiving, so that there's no travel back and forth, and limiting the travel around the time where we're going to be at most risk of a second wave of COVID-19. They're also talking about having most of the classes done online, most of the larger classes, to avoid close interaction of large groups, and to actually use those large hallways and lecture halls for small group gatherings in person. It's funny, my daughter's taking courses this summer, and she comments to me that this virtual thing is kind of nice because she can watch her lectures at 1.5 speed and watch an hour-long lecture in 40 minutes. I never thought of that. I'm not smart enough to think of that, but that's pretty clever.
That's great. Couple more questions, Dr. Starnes. One viewer says, as a past board member of the Christiana Care Health System, I am grateful for the insights from Washington. Thank you. They further state that they have heard that CMS is looking into reimbursement for video medical sessions with primary care doctors. Have you any insight on this?
Yes, so we have passed laws in Washington State to allow for reimbursement for telehealth visits. The visits must be documented in terms of time. And so you have to basically record the exact amount of time that you spent with that patient. Initially, when we started to do these telehealth visits, which I think are very valuable, when we first started to do the telehealth visits, people were worried that if we didn't have a license to practice medicine in Idaho, how could we see a patient from Idaho? And I flipped that on them and said, well, you're not going to Idaho to see the patient. The patient is coming into your office in Seattle to see you. So you only need to have a license to practice medicine in the state of Washington. So we had some issues like that, but I just did a telehealth visit with a woman from Kansas City the other day. And it's great because we can, that person doesn't need to travel all the way to Seattle to see me, but we can get the visit mostly done. I can't perform a physical exam, but I can ask them to show me certain parts of their body. And I work in an image-based specialty, so I can pull up their CT scan images and review them on the screen with them live.
Great, great. One more question I think we have time for. And this viewer asks, most recently there is growing concern about multi-symptom inflammatory syndrome in the pediatric population. This appears to be caused by a hyperimmune response to COVID antibodies. Will this lead to fear that vaccines in children may lead those in this disease developing vaccinations in kids?
Yeah, so this is a very rare event. I know that it's been hyped in the media, but it is a very rare event. And what you're referring to is Kawasaki's disease. And Kawasaki's disease is a systemic inflammatory response with a vasculitis. It can cause a vasculitis. It can cause conditions of the heart. It can cause this massive inflammatory response. And that can be from any virus, not just COVID-19, but any virus. I think what they're labeling this is something that's very specific to the COVID pandemic, but it's a very rare event.
Very good. And I'll just throw out this one last comment, not really a question, but a thank you for your service to our country. It is a fair observation that your 15 years in uniform prepared you to assess data and reach conclusions and make decisions quickly. Combat settings have an interesting way to focus attention on items of real importance and defer to lesser items. Thank you again.
Well, thank you for that comment. I would just add to that this is the easiest combat deployment you could ever have. And I'll couch that by saying that I get to take a hot shower every day. I didn't get to do that over there. I get to sleep in my own bed with my wife. I get to eat or drink whatever I want. And I get to go to work and I'm not getting shot at. That's the biggest part. I'm not having mortars or bullets thrown my way. So, staying at home is not a hard thing to do. It is hard not to be social with people. But as far as combat deployments, this is one of the more memorable but easier ones.
I can understand. I want to just thank you again for being with us and for sharing all of your stories, your experience, and your perspective with all of our viewers. Thank you.
My pleasure.
I'd also like to
just having me.
I'd also just like to thank all of our clients and guests for joining us today. We are eager to get some feedback and we'll be sending out a brief survey. So I invite you all to share your thoughts with us. Just in closing, I think it's safe to say that COVID-19 has really changed everything for us. We are a country where over 100,000 people have lost their lives and over 40 million have lost their jobs in a matter of months. We cannot change what has happened, but we can control how we respond. There's no going back to normal, and maybe that's a good thing. I think we can all take the lessons from COVID-19 to heart and do our part to help protect and support our communities, our healthcare workers, and be better than normal. Stay safe, be well, and thanks again for joining us, and we look forward to seeing all of you soon. Good day.